Welcome to Inpatient Resident Assessment, a case for bedside rounding, a production of the University of Cincinnati Internal Medicine Residency. The learning objective for this presentation is to identify opportunities for resident assessment found at the bedside but not in traditional table rounds. Traditional ward rounds often consist of a resident reading an H&P or a series of H&Ps to an attending with other residents in attendance. In this first example, see if you can spot opportunities for feedback for this resident, in particular for history and physical, plan determination, and communication skills.
Hey, Dr. Stahl, I got a night float for you. Are you ready?
Mm-hmm.
Awesome.
Go ahead.
So he's a 36-year-old guy who came to his primary care physician 3 days ago with a productive cough with green sputum. He also had some shortness of breath. Said it kind of came on all of a sudden, and it's been progressively getting worse and worse over the past 3 days. He's had intermittent fevers that have maxed at 103, but they respond to Tylenol and they respond to ibuprofen. He seems to feel better. He's had some right-sided chest pain that seems to be pleuritic in nature. And then he really has never been ill like this in the past. He says he hasn't had any ill exposures, denies hemoptysis, denies orthopnea, and no rigors at all. Review of systems really was just fatigue and a little bit of loss of appetite. Other than that, was completely negative. He has a past medical history of a bicuspid aortic valve, but he's been completely asymptomatic and has never had a problem with it. From a surgical standpoint, he had a tonsillectomy as a kid and an ACL repair as an adult, but no other surgeries that he's ever required.
Okay.
He smokes 1 pack of cigarettes and has for the past 20 years. Didn't really act like he had any interest in quitting. He's been sexually active with 1 lifetime female partner. His mom has diabetes, dad has emphysema, and then really 2 other male siblings that had no medical problems. Last night in the ED, he had a temp of 102 and a heart rate of 102, blood pressure of 126/86. He was satting 84% on room air, but he came up to 96% with 3 liters of oxygen. He was diaphoretic and looked pretty fatigued, kind of worn out. Pupils were equal, round, and reactive. Extraocular muscles were intact. Oropharynx was clear, no lymphadenopathy. Thyroid was good, carotid upstrokes were full, a bruit was heard on the right side. Had some wet crackles at the right base, but dullness of percussion was absent. Heart was regular rate and rhythm, and the murmur, he did have a 3 out of 6 systolic ejection murmur. I heard no diastolic component, no gallops, and it was heard best at his right upper sternal border. Abdomen was soft, extremity exam was normal. We got several labs in the ED, and he had a white count of 22,000 with 20,000 bands. H&H was fine, platelets were good. He had a renal panel with a BUN in the 30s, 34, creatinine of 1.2, LFTs were normal. He had a chest x-ray with a right lower lobe infiltrate, but otherwise was fine. So for an assessment and plan on him, he was a 36-year-old guy, like I said, smoker, productive cough that came in with pleuritic chest pain, fever, and hypoxia. All signs seem to be pointing towards community-acquired pneumonia, we thought. We went ahead and sent 2 peripheral blood cultures because of the bicuspid aortic valve, and we put him on Rocephin and azithromycin to cover all of the typical and atypical bacteria that we have here in our hospital. Today he's feeling a bit more comfortable, but I think he still had a fever overnight. He still has an oxygen requirement. We're going to watch the peripheral blood cultures closely because obviously we're concerned about endocarditis, but I think he's stable from the acuspid or the bicuspid aortic valve, so I don't think we need to do an echo or any other further workup at this point. I think that's it.
Okay. Anything else to add, Ryan?
Oh.
So this is the guy with the pneumonia, right?
And the bicuspid valve, yeah.
Okay, let's see him. Hi, Mr. Jones.
Hi.
I'm Dr. Saul. I'm the supervising doc on the team. I heard about you from Dr. Kelleher. It sounds like you've got a pneumonia. How long have you been feeling bad for?
Feeling crummy for about 3 or 4 days now.
Okay, what kinds of symptoms have you been having?
Yeah, I've been coughing up stuff for a few days, and past few days it's turned really dark green. Had some fevers and some chills and things. Talked to my doc. After I was short of breath, he said I might have a pneumonia, so he told me to come on in, so I did.
Okay. Mind if I take a listen to you?
Sure.
Okay. You can just breathe normally. And can you lean forward for me?
Mm-hmm.
Okay. Take a deep breath. Again. One more. You can lean back.
Sure.
Yeah, I agree with the team. It sounds like you have a pneumonia. We're going to start you on some antibiotics through your IV,
Okay.
and hope you feel better in a couple days.
How long do you think I'll be here?
Just a couple days.
Okay.
Couple days.
Any questions for us?
No.
Okay,
All right.
take care.
See ya.
After seeing this resident in action in traditional rounds, how well will you assess the following skills? Acquiring an accurate and relevant history. Develop an evidence-based diagnostic and therapeutic plan. Demonstrate respectful behavior to all members of the healthcare team. And assess for patient self-efficacy. And what constructive feedback could you offer to this resident? Take a few moments to stop the video and reflect on these questions. Once you've done that, restart the video for the second part of this presentation. In the next part of this presentation, we will present to you the same case only done at bedside. After this presentation, we will ask you to assess the resident using the same questions that you just answered. These are not perfect rounds, nor are they meant to be. They're meant for you to find some things that you'll be able to give feedback on. If you need to see perfect rounds or an idealized version of what bedside rounds might look like, the last part of this presentation will give you an address at our YouTube channel that you can go and check it out.
Is this Mr. Jones?
Yeah.
Okay. Remember, I've read your HMP, I've looked at the nursing notes, I've seen the labs and the imaging, so I'm kind of up to speed on him. Is there anything else you want to talk about before we go in?
No, I think I'm ready.
Okay.
I'll go grab the nurse and pharmacist.
Okay.
Okay. Good morning, Mr. Jones. This is the purple team like I was telling you about last night. We're going to talk about what brought you into the hospital. Is that okay?
Yeah, you got a big team here.
Yeah. This is Ryan, the senior resident you met last night. And this is our boss, Dr. Saul. She's the
Nice to meet
attending
you, sir.
physician. This is Stephen, your nurse for the day. And this will be Katie, the pharmacist. She'll be helping us out.
Hi.
Anything happen overnight, Stephen, I need to know about?
Yeah, Mr. Jones had a fever of 102.5 overnight. We called and notified the night team, and the intern placed a PRN Tylenol order.
Well, why did you call the nurse? The order is definitely in. It comes in the order set. You must not have looked at the orders because I know it's in there. Is it all right if we get started?
Yeah, sure.
All right, Mr. Jones is a 36-year-old guy that came to
Address
us.
him.
All right, Mr. Jones is so you're a 36-year-old gentleman. Came to your primary care physician yesterday for some shortness of breath. You had a cough with productive of sputum and some pleuritic chest pain. You said the shortness of breath had been getting worse, and you had these fevers, I think, to like 102 or 103. You had been using ibuprofen, and the ibuprofen had made the fevers go away, and you felt better, but then it seemed to always come back, if I remember correctly. You also had some fatigue and some anorexia, but really no other symptoms. He has a bicuspid aortic valve, but he's been completely asymptomatic from the bicuspid aortic.
Remember to address him.
Yeah, you have a bicuspid aortic valve, but it has never caused you any problems. And you have a 20-pack year smoking history of cigarettes, and you're not interested in quitting at all.
I mean, I'd like to.
Okay. He's also sexually active with one lifetime female partner, and he has
Actually, I talked to the ED doc about this. You didn't ask this. I have a male partner. We've been together for 15 years. He's HIV negative.
His mother has diabetes, and his dad has emphysema, and he's got 2 male siblings that are completely fine. He had a temperature of 102 Fahrenheit and a blood pressure that was normal down in.
Remember him.
He had a temperature of 102, a heart rate of 102. Your blood pressure was 126/86, which is good, and your heart rate was 102. Your oxygen levels were low, and you required a couple liters of oxygen to bring it up to 96%. He was diaphoretic and appeared short of breath. He had some crackles in his right lung base, but no dullness to percussion, and he had a 3 out of 6 systolic ejection murmur that we heard best in the right upper sternal border. The rest of his exam was completely unremarkable, though.
So what he's saying is we heard a sound in your heart that is pretty consistent with the valve problem that we know you have.
Sure.
And what they heard in the lung was signs of infection or inflammation, which again would be consistent with the pneumonia.
Okay.
Would it be okay if I took a listen to you and
Sure.
pointed some things out for the team?
Uh-huh.
Okay. Take a listen to your lungs first.
Mhm.
Deep breaths. One more. You can lean back. And you could just breathe normally. I'm listening to your heart here.
Okay.
So actually, he has another component to his murmur. Stay leaning forward for me. I just want to point something out to them. Take a listen and see if you can hear the diastolic component, and make sure you feel his pulse at the same time so you know when it's coming. Do you hear that second lower component?
I do hear it.
Okay.
Huh.
And again, this is all things that are consistent with the valve abnormality you have.
Okay.
So how about his labs and x-rays?
He had a white count of 20,000 with bands of 20%, and a chest x-ray that showed actually, your chest x-ray showed in the right side that you had a spot on it that looked like pneumonia, actually. Just to kind of sum everything up for you, so you're a 46-year-old and you've smoked in the past, and you have all the features of pneumonia. So when we admitted you, your oxygen levels were kind of low, so that for that reason we put you on the supplemental oxygen in your nose, and we put you on a couple IV antibiotics called Rocephin and another one called azithromycin. The reason we put you on those two is they cover all the bacteria that we see most commonly in this area. We're going to keep giving you those medicines through the IV, but you're going to get better slowly, and once you get better, we're going to switch you on over to the oral antibiotics that you'll take by mouth when you go home.
Okay.
So I know that was kind of a lot of numbers that we gave you.
Yeah.
Dr. Kelleher did a great job of telling you what the plan's going to be.
Yeah.
But I didn't want you to be, put off by all that medical
Yeah, what are the numbers?
terminology.
I didn't really...
Really, the white blood cell count is a marker of infection or inflammation.
Okay.
And it's a type that's pretty consistent with the pneumonia that you have.
Okay.
Same thing with what we saw in the chest x-ray.
Okay.
Okay. Dr. Kelleher, is there anything you want to do for his bicuspid aortic valve?
Oh yeah. Yeah, we should get it, because we heard that new component in the murmur, we should get an echo of your heart.
What's an echo?
Oh yeah, an echo is an ultrasound of your heart, so we can look closely.
Okay.
Also, Mr. Jones, I'm the pharmacist on the team. I understand you're interested in quitting smoking. Is
Yeah.
that okay if I come back later and we talk about it some more?
Yeah, I'd like to. That'd be good.
Great.
Do you anticipate any needs on discharge, any home oxygen?
Oh, that's a good question. I don't think so. I think he'll be fine.
So I've ordered a transthoracic echo, and I've ordered some Tylenol as needed, and have placed an oxygen wean order. Anything else we need to order?
That's good. So, Mr. Jones, can you give me a recap and go over the plan so I know we did a good job explaining it to you?
Sure. So I have a pneumonia. I'm going to be on some antibiotics. You're going to take an ultrasound of my heart, and then we'll see if I can switch to pills maybe later. And we're going to talk about quitting smoking back there.
Great. Any questions for us?
That's about it.
Okay. See you later. Take care.
Thank you.
See you, Mr. Jones.
Now that you've seen this resident in action at the bedside, how well will you assess the following skills? How well did he acquire an accurate and relevant history? How well did he develop an evidence-based and diagnostic therapeutic plan? How well did he demonstrate respectful behavior to all members of the healthcare team? And how well did he assess for patient self-efficacy? And what constructive feedback could you offer to this resident had you seen these rounds at bedside? Take a few moments and stop the video, reflect on these questions, and then when you're ready, restart the video for the last part of this presentation. When deciding where to hold rounds, you may ask yourself what assessment is best done at the bedside. Take history taking, for example. If you're simply read an H&P by a resident and you cannot confirm that the history is actually correct without the patient, how can you assess whether the resident was good at taking a history? If you're simply read a physical exam without being able to see the patient right then and there and give immediate feedback on exam, your assessment is probably not going to be as effective as it might be. Communication skills at the table are limited because they're only between a few types of practitioners. At the bedside, you get the patient plus a chance for the entire interprofessional team and to see how that resident interacts with that team. And we believe clinical reasoning is better assessed at the bedside because part of clinical reasoning is problem solving with the patient and driving that patient towards a sense of self-efficacy and understanding. It's almost not possible to do that at the table rounds. So table rounds are really an assessment of what a resident knows at the bottom of Miller's pyramid, while bedside rounds are what physicians do, and you can assess at the top of this pyramid how a resident performs in taking care of a patient. The learning objective for this presentation was to identify opportunities for resident assessment found at the bedside but not in traditional table rounds. We've hoped that you found a few of these opportunities in our presentation and will consider doing bedside rounds at your institution. If you'd like to see more videos in this series and other series including bedside presentations and other medical education topics, go to YouTube and type in the keyword UCINTMED.